Hello and welcome. Whether you're a healthcare professional or part of our training network joining us from the United States or around the globe, we are so glad you are with us. I'm Nancy Brown, Chief Executive Officer of the American Heart Association. It's my honor to help launch our 2025 guidelines for CPR and emergency cardiovascular care. For more than 5 decades, the American Heart Association has been at the forefront of resuscitation science and training. Our guidelines are peer-reviewed by global experts and rooted in a rigorous review of emergency science, systems, and education. As with previous guidelines, we've translated the very latest evidence into clear recommendations that empower people to act when every second counts. Together with leaders at the American Academy of Pediatrics, we've also co-developed pediatric and neonatal guidelines for children and youth. Every day, these guidelines are giving our families, our friends, and our neighbors a second chance at a long and healthy life. And it starts with you. This year, more than 22 million people will be trained in CPR and ECC, supported by an incredible network of over 400,000 instructors and 3,500 training centers in 92 countries. Your dedication, expertise, and compassion makes this impact possible. And these guidelines are more than just updates. They are part of a bold vision. By 2030, the American Heart Association's goal is to double survival rates from cardiac arrest. Today, only 1 in 10 people who experience a cardiac arrest outside of the hospital will survive. This critical need drives our Nation of Lifesavers movement and our global advocacy efforts to ensure that everyone everywhere is prepared to be a vital link in the chain of survival. And we're already seeing progress. In just 2 years, the percent of adults in the U.S. who feel confident performing CPR has grown from 33 to 39%. That's a meaningful shift, and we're continuing to build on this momentum. Your participation and leadership are more important than ever to allow us to save more lives. Today, we're excited to launch new CPR and ECC training materials that reflect the latest guidelines. We're releasing these materials simultaneously in both U.S. and international English, with many additional languages to come, so you can start using them right away. Thank you again for joining us to learn more about the new CPR and ECC guidelines. Let's get started.
Good morning, everyone, and welcome to the Science Overview webinar for the launch of the 2025 American Heart Association Guidelines for CPR and Emergency Cardiovascular Care. I'm Dr. Ash Panchal, AHA and ECC Committee Chair and Professor of Emergency Medicine at The Ohio State University. It's a privilege to be with you today as we kick off this exciting day of webinars. First, we want to thank Nancy Brown, our CEO, for her inspiring remarks and for reminding us what this moment represents. The guidelines are more than scientific updates. They are part of a relentless, decades-long effort to turn evidence into action and to bring life-saving science to every community, everywhere.
And I'm Dr. Maya Dewan, a member of the American Heart Association Pediatric Basic Life Support Task Force and the Division Chief of Critical Care Medicine at Cincinnati Children's Hospital. Whether you're joining us from across the United States or from around the world, we're thrilled to have you here. The release of the guidelines is always a milestone moment. You may be wondering what exactly the guidelines are and how they are developed. The guidelines are a multi-year process that all starts with the International Liaison Committee on Resuscitation, also known as ILCOR, which produces the International Consensus on Science with treatment recommendations. The American Heart Association is proud to be a founding member of ILCOR. The association's science and clinical experts then perform structured evidence evaluation, analysis, literature cataloging, and scientific evidence reviews, which are then drafted into the official American Heart Association guidelines for cardiopulmonary resuscitation and emergency cardiovascular care, CPR and ECC. These are used across the US and around the world. And together with the American Academy of Pediatrics, we developed the official pediatric and neonatal resuscitation guidelines as well. This rigorous process ensures that we recommend today reflects the best available science. The association translates the guidelines into resuscitation education and training. This ensures that students always receive the highest quality CPR knowledge and skills.
These guidelines are also a bridge connecting research, training, and practice. Since the very first association guidelines were published in 1966, each new edition has advanced how we save lives both in and out of the hospital. And this year's updates align with the association's 2030 impact goal to double survival from cardiac arrest.
During today's webinar, we'll explore what's new, what's changed, and what it all means for work. You'll hear key highlights across adult, pediatric, and neonatal resuscitation, as well as updates in systems of care, special circumstances, and education. We'll have a live Q&A where we'll answer your questions in real time, and then provide closing remarks before the webinar ends. This is the first in our three-part guideline webinar series today, and truly sets the stage for everything that follows. Together, these conversations represent the next chapter in resuscitation science.
Thank you again for being here, for your commitment to continuous learning, and for being part of this community that brings science to life. We'll begin our webinar with Adult Advanced Life Support with Dr. Michael Kurz, Chief of Emergency Medicine at the University of Chicago Medicine, Professor of Emergency Medicine, Pediatric Emergency Medicine at the Pritzker School of Medicine at the University of Chicago, and Chair of the 2025 Advanced Life Support Guidelines Writing Group. Dr. Kurz is a national leader in resuscitation, systems of care, and post-arrest management, having authored more than 170 peer-reviewed publications in the field. Please join us in welcoming Dr. Michael Kurz.
Good morning. Thanks, Ash. I appreciate having the opportunity to be here on behalf of the American Heart Association to announce the new ALS guidelines. The ALS work group has worked tirelessly for 5 years to put these together. And there's a couple of things that I'd like to highlight that are different than have been in years past. Let's go through really the top 10 large changes. The ALS work group has acknowledged that a rapid assessment of clinical stability is absolutely essential to make sure that the appropriate ALS treatment is delivered. In many instances in the ALS guidelines, you'll see that the treatment changes based on the urgency, and when I say urgency, frankly, the instability of the patient in front of you. Typically, this deals with arrhythmia treatment that we'll go into later on in this webinar. But fundamentally, there is now a discussion about how the assessment of clinical stability should actually hinge on poor organ perfusion rather than in the past where it is hinged on kind of arbitrary numbers or arbitrary vital signs. Another fundamental change, the ALS work group has endorsed we'll say, go big or go home approach to first shock energy settings for atrial fibrillation and A-flutter. For those of you who are familiar with the guidelines from years past, you'll remember we used to take a stand that suggested that you should use a low energy setting and then use multiple shocks to escalate. We'll review later that the science now suggests a go big or go home approach, meaning you shock at the highest setting to start and don't attempt to escalate. We have evaluated the termination of resuscitation guidelines in the context of the vast majority of EMS agencies in the United States. Outside the United States, there are EMS agencies in general fall into either BLS, basic life support, or ALS, advanced life support. In the US, we have a very interesting hybrid where most EMS agencies are both BLS first responders or BLS agencies that are then backed up by ALS agencies. In this context, rather than applying one or the other termination or resuscitation rules, a universal TOR rule should be used. There is lots of discussion in the new guidelines about vector change and double sequential defibrillation. These are reasonable therapies to be considered for shock refractory VF. However, we acknowledge in the guidelines, simply because the popularity and the use of both of these techniques has proliferated significantly in the pre-hospital space, we acknowledge that there needs to be more investigation into the techniques. Patient candidacy is very important. Who should get shocked with these techniques and when? And the development of new technology to make sure that we optimize shock delivery. It's actually very technical trying to do this. And currently we just do it manually. Let's talk about a few others. We discuss at some length heads-up cardiopulmonary resuscitation, or heads-up CPR. Many EMS agencies are familiar with this. This is CPR that is conducted with impedance threshold device, an ITD, a mechanical method of providing CPR, and then another mechanism to elevate the head of the patient while this process occurs. We have evaluated the literature, and the work group in the guidelines, will discourage its use outside of the setting of rigorous clinical trials with appropriate subject protections, meaning ethical protections with appropriate oversight by an institutional review board. The guidelines in the past have included recommendations about antiquated techniques like administering intra-arrest medications down the ET tube. Or providing intracardiac epi. We've acknowledged that these outdated, or in some instances extraordinary, procedures have been replaced by safe and efficient modern equivalents that frankly work better. And so those outdated recommendations, those outdated techniques, have been removed from this set of the guidelines. Point of care ultrasonography, or POCUS, is a wonderful tool in the setting of cardiac arrest if it is used by experienced professionals, and it does not come at the cost of evidence-based resuscitation, meaning it does not interrupt the rest of the cascade of guidelines in the setting of cardiac arrest. It can be very helpful to diagnose reversible causes. It has to be done without interrupting the victim's care. An acknowledgement that pulseless ventricular tachycardia is always unstable and should be treated immediately with defibrillation. Using drugs in that setting or other methods to attempt to correct that arrhythmia simply cause delays in shock delivery and frankly worsens outcomes. IV access remains the first line choice for drug administration during cardiac arrest. With the advent of IO, intraosseous access, in the last 10 to 15 years, because of its ease of use and frankly how quick it is, there has been a movement towards the use of IO access primarily in the setting of cardiac arrest. The guidelines and the work group acknowledge that intravenous access, because of its predictability in reaching drug levels fast, remains the first line choice for drug administration. IO access is perfectly fine if for some reason IV access is not feasible or is somehow delayed. Finally, in reference somewhat to the first statement in the ALS Top 10, acknowledgement by the guidelines that arrhythmias can be both the cause and a manifestation of clinical instability. The easiest example of this, or the simplest example of this, is atrial fibrillation with rapid ventricular rate, or AF with RVR, in the setting of sepsis. In the setting of sepsis, in distributive shock, the rapid AFib may very well be a manifestation and not the cause of the instability. An astute clinician using these guidelines should be able to assess the cause of the instability and then treat the underlying cause, whether that is the arrhythmia or it is another condition causing the arrhythmia. One of the things we didn't discuss yet, but is new for the guidelines, is there's a significant amount of discussion about vasopressor medications. The most common of these is epinephrine. The update for epinephrine is we should continue to use it. The timing should generally be the same. It should be administered in patients with a shockable rhythm or an unshockable rhythm. And in shockable rhythms, you administer epinephrine as soon after initial defibrillation has failed. We also make a statement about the use of vasopressin either alone or in combination. Previous guidelines have endorsed the use of this medication. New science suggests that vasopressin either alone or in combination with other vasopressor medications or as a substitute for epinephrine offers no benefit in the setting of adult cardiac arrest. Since the last guidelines in 2020, there's also been a lot of work in non-vasopressor medications in the setting of cardiac arrest. These drugs would include beta blockers, the reemergence of bertilium back to the US market. It's been gone for years and years and years after being included in the guidelines. I think way back, certainly the first time I worked on the guidelines in 2010, it was there. Procanamide, sotalol for ventricular fibrillation or pulseless VTAC. In these instances, these medications are all of uncertain benefit and in fact probably distract from evidence-based therapies that we know work in the setting of cardiac arrest. And with that, let me turn this back over to my buddy Ash Penchel. Thank you very much for your attention to these key updates to the ALS guidelines. Now let's take a look at how the foundational science of basic life support has evolved. As I mentioned, my buddy Ash here will walk us through the 2025 updates to adult basic life support. Ash, it's all yours, man.
Thanks a lot, Michael. So let's dive right in and start talking a little bit more in detail about the key concepts and the top 10 updates to the adult basic life support. So the updates of the 2025 Basic Life Support Guidelines features the key concept that are critical to improve survival in the initial minutes of cardiac arrest. So let's first consider the initiation of resuscitation. In adult cardiac arrest, when someone suddenly collapses, resuscitation should be conducted where the patient is found, as long as the high-quality CPR can be given safely and effectively. Now, what this does is it prioritizes the immediate, rapid, life-saving interventions to optimize neurological survival. Now, in the frame of this concept, if you're a lone responder and you're the first person there, you need to identify a patient in cardiac arrest. The first thing you should do is activate emergency response system and then immediately start CPR. This supports all of our training focused on the basic concept of calling 911 and pushing hard and fast. When starting CPR, optimal rescuer position can lead to better CPR. The writing group reviewed multiple simulated crossover RCTs looking at this specific question. Their results: rescuers should perform chest compressions with the patient's torso approximately at the level of the rescuer's knees. This allows for optimal depth and recoil. Now, in all these situations, an important question is always, as healthcare providers, should we provide breaths? And numerous studies have shown improved outcomes with ventilations when they're provided with chest compressions. Now, as CPR duration increases, our arterial oxygen content decreases, highlighting the importance of providing these fundamental ventilations. Therefore, for healthcare professionals with training and understanding, it is reasonable to provide chest compressions and ventilations for all patients, no matter the etiology of the cardiac arrest. Now, this leads to the next question: how much breath or tidal volume to give? Well, this is challenging since equipment to measure tidal volumes are generally unavailable, but a reliable method for assessing ventilation is still watching the chest rise. Therefore, it is reasonable to give enough tidal volume to produce that visible chest rise, but keep in mind, we have to remember to avoid both hypo and hyperventilation since these directly impact neurological outcome. Now, we've talked a lot about the quality of CPR, but can a machine do this better than us? Well, this has been a question for multiple years, and in this guideline, the writing group clearly notes that the routine use of mechanical CPR devices is not recommended in adult cardiac arrest. We will touch more on this topic a little later in my discussion. Now, a minute ago, we talked about having good tidal volumes through seeing a chest rise, but what is that respiratory rate? Now, for adults who are not breathing normally but have a pulse, it is reasonable for rescuers to provide 1 breath every 6 seconds or 10 breaths a minute. Now, this is a good benchmark to maintain normal capnia or normal ventilation. This way, we avoid those abnormal ventilations that lead to our poor neurological outcome. The updated BLS guidelines also provide key recommendations for some specific special cases that are important for us to consider. The first one you see right above. Obesity affects more than 40% of adults in the United States, and it's a significant risk factor for cardiac arrest. With this in mind, in these guidelines, a scoping review of 34 observational studies found no evidence to support changes from standard CPR for obese patients in cardiac arrest. Therefore, for adult cardiac arrest patients with obesity, CPR should be provided by the same techniques as the average weight patient. Now, another special case is the situation of severe foreign body airway obstruction. Now, data in this area is limited. There's no RCTs, and no one's going to do an RCT on this specific topic right off the bat. However, recent studies of a cohort of over 700 patients with severe foreign body airway obstruction showed that back blows were associated with significantly improved rates of foreign body obstruction relief than abdominal thrusts and less injuries than abdominal thrusts. Based on this evidence, for adults with severe foreign body airway obstruction, rescuers should perform cycles of 5 back blows followed by 5 abdominal thrusts until that object is expelled. And finally, the writing group highlights the importance of clinician-provider safety. As clinicians, we need to consider keeping ourselves safe. During cardiac arrest, it is reasonable for rescuers to use personal protective equipment while performing CPR. Now, these are the top 10 updates for basic life support, but I do want to highlight a couple key BLS concepts that are important for us to know. Let's start with pad placement. In this update, the writing group provides standardized verbiage and visuals on anterolateral pad placement. You can see here that the first pad is on the person's right upper chest under the clavicle, and the lateral pad is horizontally placed on the person's left lateral ribs below the axilla in the mid-axillary line. In this comprehensive update, there's also a new adult BLS algorithm for lay rescuers, which integrates opioid-associated emergencies. Still, the key focus of the algorithm is the same. Call 911, start CPR, use an AAD. That's still the hallmarks of what we do. However, this algorithm also recognizes that in some situations, rescuers may suspect an opioid overdose and may be able to provide naloxone. This occurs later in the algorithm. Now, the thing is, it is important to see the same integration in the adult BLS algorithm for healthcare professionals. There is no longer separate algorithms for opioid emergencies. These are all integrated together. As I discussed a little earlier, there are new recommendations for adults with severe foreign body airway obstruction, as well as updated algorithms. Again, based on the evidence review, rescuers should perform cycles of 5 back blows followed by 5 abdominal thrusts. If the person becomes unresponsive, start CPR. Now, there are some additional important concepts that we need to consider in this situation. The first being blind finger sweeps. These should not be performed in adults due to the potential risk of worsening the airway obstruction, and that outweighs any benefit of actually doing the technique. Secondly, if the rescuer is unable to encircle the patient's abdomen, go for 5 back blows followed by 5 chest thrusts until the object itself is expelled. In this recommendation, the writing group actually calls out particularly the patient in the late stages of pregnancy, such that we protect that patient. There are some other terminology changes which are really important for all of us to note. For instance, the first one at the top here is rescue breathing has now been replaced with differential verbiage. So for breaths, mouth to mouth, pocket mask, or barrier device, that's breaths. For ventilations, it's for bag mask device or anything beyond this, like an advanced airway device. bystander was been replaced with lay rescuer for clarity in their role as a lifesaver, to make that really transparent. As we mentioned earlier, routine use of mechanical CPR devices is not recommended in cardiac arrest. Now, this question was rigorously addressed by the writing group with support of our international ILCOR partners who closely evaluated the question of mechanical CPR devices. They noted several RCTs demonstrating no improvement in survival with mechanical CPR devices. And in fact, the paramedic trial showed worse neurological outcomes at 30 days, 3 months, and 12 months. With this in mind, the writing group clearly notes that the routine use of mechanical CPR devices is not recommended in adult cardiac arrest. Now, being an EMS doc, this was really impactful for me because it makes sense, but at the same time, there is still a critical role of these devices in clinical care. Mechanical CPR devices may be considered in specific settings where manual compressions may be challenging or dangerous to the healthcare provider. The key here is to weigh the potential benefits of the device against the logistical factors like crew safety, transport times, available personnel for CPR, against the impact being CPR quality and neurological outcome. Finally, the question of continuous chest compression versus 30-2 is still an area of discussion. After a thorough reevaluation of the available data comparing continuous chest compressions and uninterrupted CPR with ventilation pauses, the majority of studies show no difference. However, there is one important caveat that's come up, is that with asynchronous breaths, this does not allow the rescuer to monitor the adequacy of ventilation. Because it's not possible to evaluate those ventilations during continuous chest compressions, the writing group put value on the ability to monitor using 30-2 CPR. Therefore, the writing group notes that the adults with cardiac arrest without an advanced airway, healthcare professionals may consider continuous chest compressions with asynchronous breaths. These are the highlights for the adult basic life support section. Now, to help us transition into the next area of the guidelines, I want to hand it back to Dr. Maya Dewan, and who will set up our discussion of pediatric and neonatal resuscitation.
Thank you, Ash. As we shift from adult resuscitation to the care of infants and children, we're proud to highlight the sections developed in collaboration with the American Academy of Pediatrics, also known as the AAP. These recommendations reflect years of shared science and commitment to improving outcomes for our youngest and most vulnerable patients. We will begin with Dr. Javier Lassa, who co-chairs the Pediatric Advanced Life Support Writing Group. Dr. Lassa is a leader in pediatric critical care and resuscitation education, and he'll walk us through the key updates shaping how we respond to pediatric emergencies in both in-hospital and pre-hospital settings. After Dr. Lassa, we'll hear from Dr. Tia Raymond, who co-led the Pediatric Basic Life Support Writing Group. Dr. Raymond is a pediatric cardiologist and resuscitation expert who has devoted her career to improving survival for children experiencing cardiac arrest. She'll cover updates to the pediatric chain of survival and new recommendations that support early, effective interventions for children of all ages. Then we'll close this section with Dr. Henry Lee, co-chair of the Neonatal Life Support Writing Group. Dr. Lee is a neonatologist and professor of pediatrics at the University of California, San Diego, and he also serves as the newly appointed National Senior Director of Resuscitation Science for the American Heart Association. He'll share key updates from the neonatal guidelines and discuss how the new recommendations strengthen the earliest moments of care after birth. With that, let's begin. Dr. Lassa, over to you.
Good morning, and thank you, Maya. I appreciate the introduction. As Dr. Dewan said, my name is Javier Lassa, and I'm a board-certified pediatric cardiologist, critical care medicine specialist, and resuscitation science researcher at Children's Health Systems of Texas and at the University of Texas Southwestern Medical Center here in Dallas, Texas. I'm the co-chair of the 2025 PALS Writing Group, here representing the American Academy of Pediatrics, and I'm really excited to join you today to share some insights into this year's PALS guidelines. I'm presenting on behalf of a fantastic group of writing group members, as well as my fellow co-chair of the 2025 Writing Group, Dr. Alexis Topchin, who's a representative of the American Heart Association and the former co-chair of the 2020 combined PALS and Pediatric Basic Life Support Guidelines writing groups. Now, as we are focusing on PALS for the next few minutes, it's important to recognize that PALS focuses on providing guidance for healthcare workers beyond basic life support, which of course is a recognition of cardiac arrest in the first response, which is the first response initiation of CPR that we see in basic life support. So PALS goes into advanced management of critically ill infants and children throughout the cardiac arrest spectrum, and is geared for pediatric patients, infants, and children up to 18 years of age. And although pediatric advanced life support guidelines may be applied to newborn infants younger than 28 days of age based on pathophysiology and institutional practices, we do recommend neonatal guidelines be followed at birth to adjust those unique aspects of transitional physiology. So let's jump in. A lot hasn't changed in this year's guidelines, but the 2025 guidelines do have some important changes related to drug administration during CPR, CPR titration, CPR quality, and post-cardiac arrest care we want to emphasize. And so we, of course, continue to emphasize the importance of high-quality CPR as we currently understand it. Namely, that providers should be focusing on appropriate chest compression rates as well as age-appropriate depth. We want to allow full chest recoil between compressions. We want to focus on minimizing interruptions, all the while providing adequate ventilation for the pediatric patient population while avoiding hyperventilation. Ventilation rates were increased in 2020, and that remains the same this go around. Secondly, in addition to the 2020 recommendations of administering either intravenous or interosseous epinephrine every 3 to 5 minutes during pediatric cardiac arrest, our first big change is emphasizing that during CPR for non-shockable rhythms, such as PEA or asystole, epinephrine should be administered as early as possible, as it's associated with favorable outcome for infants and children who've suffered a cardiac arrest. And previously, we had suggested within 5 minutes of the initiation of compressions. Thirdly, for initial shockable rhythms, namely pulsus ventricular tachycardia or ventricular fibrillation, rapid defibrillation remains the priority. Next, for patients with an arterial line in place during CPR, we had previously recommended titrating to a diastolic blood pressure only without clear guidance about what levels you should target because there had been insufficient data at the time. But with this iteration, the guidelines and with the publication of both a single center and now multi-center study, the data is much stronger to support targeted diastolic blood pressures greater than 25 millimeters of mercury in infants less than a year of age, and a diastolic greater than 30 millimeters of mercury in children greater than 1 year of age. And these are for children who are receiving CPR with an indwelling arterial line. And that's because the thresholds are associated with higher rates of return of spontaneous circulation and survival to discharge. As for the use of end-tidal carbon dioxide monitoring during CPR, we've updated our recommendation and continue to support the use of end-tidal CO2 for CPR quality monitoring, but also want to caution against its use when considering terminating resuscitative efforts. And this is because there's data in several studies that shows that end-tidal CO2 levels that are either less than 20 or even less than 10 still had almost half of patients achieving return of spontaneous circulation despite the low levels. And so we don't want people terminating resuscitative efforts on end-tidal CO2 alone. And then once you're in the post-cardiac arrest period, we continue to emphasize temperature management with a focus on fever avoidance. We also continue to recommend close monitoring of blood pressure to avoid secondary organ injury, including brain injury that's due to post-cardiac arrest, myocardial dysfunction, and or hypotension that often ensues. And so this is our biggest change for post-cardiac arrest care, is we now recommend a new target for both systolic and mean arterial blood pressure in the post-arrest period. Previously, we had recommended that clinicians target systolic blood pressures greater than the 5th percentile for age. And now with new data, we're recommending that you target both the systolic blood pressure and the mean arterial blood pressure greater than age-adjusted 10th percentile. So again, greater than 10th percentile for systolic and mean blood pressures for age. And this change was based on several studies, but really a large multi-centered trial that found that post-arrest blood pressures, including systolic and mean arterial blood pressures, greater than the 10th percentile were associated with higher rates of survival with a favorable neurologic outcome. So next, thanks to the work of the International Liaison Committee on Resuscitation, or ILCOR's 2024 Comprehensive Systematic Review, looking at the predictive accuracy of the post-arrest clinical exam that you'll perform, EEG, biomarkers, and neuroimaging for favorable and unfavorable outcomes, we now have a much expanded neuroprognostication guidance section with a new infographic to share with the community. As for the key takeaway from this section, we want to highlight that the single most important thing is that clinicians avoid neuroprognosticating with any single modality. None of them are accurate enough at any point, and many of them have not been studied in isolation. So in addition, we want to highlight that timing is really important for certain modalities. And so neuroprognostication, for that, we don't want this happening early because accuracy is often impacted early after the arrest. For survivors, we want to continue to stress the importance of post-discharge survivor neurologic and psychological injuries that require important screening, surveillance, and resources to manage and improve the quality of life. And lastly, we've now added a new intravenous medication to the list of possible agents to treat SVT or supraventricular tachycardias that present with cardiopulmonary compromise and are unresponsive to vagal maneuvers, IV adenosine, and electrical synchronized cardioversion when expert consultation isn't available. The cardiac arrest algorithms remain relatively the same for 2025 with some minor edits as shown in these red boxes. We've strived to simplify the language surrounding high quality CPR as well as medications. However, overall pathway and recommendations for either shockable or non-shockable rhythms remains the same with a shock, then epinephrine approach for shockable rhythms and early epinephrine for non-shockable rhythms. For the pediatric bradycardia with the pulse algorithm, we've adjusted the decision and action items to make it clear when CPR is indicated. The remainder of the algorithm remains the same. And as for pediatric tachyarrhythmias with the pulse algorithm, we've added some helpful language to help healthcare providers distinguish probable sinus tachycardia from probable supraventricular tachycardia, but the remainder of the algorithm remains unchanged. And lastly, we've updated the post-cardiac arrest care checklist and hope this helps healthcare providers provide a comprehensive approach to post-cardiac arrest care. And with that, and on behalf of the PALS 2025 Writing Group and my co-chair, Alexis Topshin, I thank you for tuning in and hearing about the PALS guidelines for 2025. Now that we've reviewed PALS, let's turn things over to the Pediatric Basic Life Support team. It's my pleasure to hand things over to Dr. Tia Raymond, who will cover updates to PBLS. Dr. Raymond.
Thank you very much, Dr. Lassa. On behalf of the 2025 AHA and AAP Pediatric Basic Life Support Writing Group, I would like to share with you an overview of our new guidelines. As always, we start with the top 10. Number 1, immediate recognition of cardiac arrest is vital to improving outcomes. For infants and children who are unresponsive with abnormal breathing, including gasping, rescuers should activate emergency medical services and initiate high-quality CPR, beginning with chest compression. High-quality CPR is the foundation of resuscitation. The key components of high-quality CPR include providing adequate chest compression rate and depth, minimizing interruptions in CPR, allowing full chest recoil between compressions, and avoiding excessive ventilation. For out-of-hospital cardiac arrest in infants and children, providing breaths in addition to chest compressions improves survival. Thus, lay rescuers are encouraged to provide breaths if they are able and willing. A respiratory rate of 20 to 30 breaths per minute is recommended for infants and children who are A, receiving CPR with an advanced airway in place, or B, receiving breaths and have a pulse. For infants, the recommended compression techniques include using either one-hand technique or two-thumb encircling hands technique. If the rescuer cannot physically encircle the chest, it is recommended to compress the chest with the heel of one hand technique. The use of 2 fingers along the sternum was eliminated due to ineffectiveness in achieving proper depth. For out-of-hospital cardiac arrest in infants and children, providing breaths in addition to chest compressions improves survival. For infants and children in cardiac arrest, an AED should be attached as soon as possible and use a pediatric attenuator and pediatric pads if available. Prompt defibrillation for VF and pulseless VT is critical with minimization of peri-shock pauses. For infants with severe foreign body airway obstruction, repeated cycles of 5 back blows, alternating with 5 chest thrusts, is recommended. Abdominal thrusts are not recommended in infants. In children with severe foreign body airway obstruction, guidance is the same as for infants, with repeated cycles of 5 back blows, alternating with 5 abdominal thrusts, as opposed to solely abdominal thrusts. Significant changes include the foreign body airway obstruction. For children with severe FBAO, repeated cycles of 5 back blows, alternating with 5 abdominal thrusts, should be performed until the object is either expelled or the child becomes unresponsive. This is a major change from 2020, where the intervention was abdominal thrusts only until the object was expelled or the child became unresponsive. Compression technique. For infants, the recommended compression technique includes using either one hand or 2 thumb encircling hands technique. If the rescuer cannot physically encircle the chest, it is recommended to compress the chest with the heel of one hand. The use of 2 fingers along the sternum was eliminated due to ineffectiveness in achieving proper depth. This is also a major change from 2020, where the use of 2 fingers was still a recommended technique. The removal of this recommendation also removes differences in compression technique between single and 2 rescuer CPR in infants. Previously, it was recommended that a single rescuer use the 2-finger technique and 2 rescuers use the 2 thumb encircling technique. Now, for single or 2 rescuers, either 2 thumbs or the heel of one hand is recommended, whichever can achieve the best depth. We also have new algorithms, both for infant and child foreign body airway obstruction. Here you see the new algorithm for infant foreign body airway obstruction, noting that if there are signs of severe foreign body airway obstruction, the activation of the emergency response system should occur, followed by, if the child is responsive, 5 back blows, followed by 5 chest thrusts. If the infant is unresponsive, CPR is to be initiated immediately. For the child, similarly, we have a new foreign body airway obstruction algorithm. Again, if signs of severe FBAO are present, 5 back blows followed by 5 abdominal thrusts should be initiated in the child who is responsive. If the child becomes unresponsive, chest compression should be started immediately. As we think about the continuum of care, our next focus is the moments right after birth. To share the latest science in neonatal resuscitation, I'll turn it over to Dr. Henry Lee.
Hello, I'm Henry Lee. I'm a neonatologist and a professor at the University of California, San Diego, and co-chair of the neonatal writing group, and happy to present some highlights of the neonatal guidelines. There are the neonatal top 10, which I won't go over in detail, but I encourage you to look over when you have a chance. But just a couple of highlights. There is a new newborn chain of care, which I'll go over more in a little bit. And we do want to emphasize anticipation and preparation. Most newborn infants do not require resuscitation and can get deferred cord clamping. And I'll highlight a change in the duration of deferred cord clamping in a minute. The priority, as has been in prior guidelines for newborn resuscitation, is effective ventilation of the lungs. We do have a new sort of a recommendation about ventilation corrective steps, which includes the potential for use of an alternative airway, such as laryngeal mask or endotracheal intubation. And as in previous guidelines, we emphasize monitoring temperature to avoid hypothermia and hyperthermia. And pulse oximetry is used to guide oxygen therapy. The chest compressions recommendation epinephrine and redirection of care are similar to prior guidelines. I wanted to now focus on some of the changes and emphases for the update, and I'll start with umbilical cord management. For term newborns and for preterm newborn infants born at less than 37 weeks of gestation, deferred cord clamping is considered beneficial for a duration of at least 60 seconds. And this is a change from prior updates, which had noted at least 30 seconds. And so for both populations, there has been increasing evidence that deferred cord clamping for at least 60 seconds can be beneficial. A change in our ventilation recommendation is that it is reasonable to provide ventilation at a rate of 30 to 60 inflations per minute in newborn infants. This is a change from 40 to 60. So the lower bound of that has changed to 30, which is also aligning with the rate when chest compressions are given. There's a change in the oxygen administration. This is already a best practice in many circumstances, but now there is increasing evidence to support that a pulse oximeter should be placed as soon as possible for newborn infants receiving respiratory support or supplemental oxygen. In addition, for those infants less than 32 weeks gestational age who receive respiratory support at birth, it may be reasonable to begin with the oxygen concentration of 30% to 100%. And this is a change from 21 to 30% based on increasing evidence that it is desirable to achieve a goal saturation of 80 to 85% by 5 minutes for preterm infants. For chest compressions, this is not a change from prior guidelines, but there's more evidence to support what has been recommended already, which is to compress over the lower third of the sternum, avoiding the xiphoid process. And we do note this best practice is also now supported with increasing evidence in the literature that it's reasonable to change the compressor every 2 to 5 minutes to avoid fatigue. This is a figure, a new visual aid that was developed by the writing group, the Newborn Chain of Care. And this provides the foundation, the context in which effective newborn resuscitation can occur with ventilation at the center, but recognizing that for optimal outcomes, there is a goal to have optimal prevention or prenatal care, as well as to follow up patients, those infants who required resuscitation for postnatal care. The updated algorithm, I encourage you to look over it in detail, and it is largely following the similar structure from prior guidelines. Just a couple of highlights is that there is a box now to emphasize the importance of umbilical cord management to think about that prior to birth. And then to note that the oxygen saturation goal targets start at 2 minutes, which emphasizes that deferred cord clamping would be occurring in most circumstances up to a minute or more, and therefore you would not know the oxygen saturation until after that time. Also, ECG is recommended prior to chest compressions. So that concludes my portion and concludes the pediatric and neonatal section. Now I'll pass it back to Dr. Maya Duan, who will introduce the supporting chapters that connect science, systems, and education.
Thank you, Henry. And thanks to all of our pediatric and neonatal presenters for your incredible leadership in collaboration with the AAP. These pediatric and neonatal guidelines are truly outstanding. They're grounded in the latest pediatric evidence, making them vital to optimize resuscitation for children. But what I really want our audience today to hear is that the most effective way we can boost survival for kids experiencing cardiac arrest is to get more lay rescuers involved. When someone steps up and starts CPR right away on a child, including both chest compressions and breaths, it can truly change the outcome. So that's why it's crucial to promote CPR training, not only for medical professionals, but also for parents, caregivers, and literally everyone in the community. The more people who know how to respond in an emergency, the better the chances are for children to survive and to have good neurologic recovery. We'll now turn to several supporting chapters within the 2025 guidelines. The chapters that bring the science together into systems, special circumstances, and education. These sections demonstrate how resuscitation outcomes depend not only on individual performance, but on how teams, hospitals, and communities work together. We'll start with Dr. James Dow, Associate Professor and Division Chief of Medical Toxicology in the Department of Emergency Medicine at UT Southwestern Medical Center. Dr. Dow is the Medical Director of Toxicology for Parkland Health and Hospital System. He'll share key highlights from the Special Circumstances chapter, including new recommendations for managing unique and high-risk resuscitation scenarios. Then, to summarize key updates from the Systems of Care section and Education section, we'll hear from Dr. Panchal. Dr. Dow, we'll begin with you.
Hello and welcome. Thank you so much for being here. I am James Howe. I am an Associate Professor of Emergency Medicine and the Division Chief of Medical Toxicology at UT Southwestern. I was the chair of the Special Circumstances Writing Group for 2025, and we're excited to share some of our top highlights with you. The Special Circumstances Writing Group looked at circumstances which were special and that had unique characteristics that led to modifications of standard ACLS or BLS. And what is also new in the 2025 guidelines is that we expanded the population for which we're covering in this chapter from adults to both adults and pediatrics. That largely increased the size of our chapter. And we also included some of the recent focus updates, including that on toxicology in 2023, as well as drowning in 2024. So taking a look at our Special Circumstances top 10, we're going to start with anaphylaxis. We suggested that you can use isotonic fluid in this pathophysiology that is very vasodilatory to help patients with cardiac arrest from anaphylaxis. The writing group does warn that the use of autoinjectors in the case of cardiac arrest may be difficult and is very poorly elucidated in the evidence. So sticking with standard IV epinephrine may be the best choice. We also suggested that you can use glucagon in refractory cases due to beta blocker exposures. In number 2, we have cardiac intervention laboratory. This is a new topic for us, and this is related to cardiac arrest that occurs in the interventional laboratory, where there could be special conditions in which you have a catheter that's already directed. You could consider intracoronary epinephrine, although the evidence there is not strong. The Special Circumstances Writing Group also expanded the recommendations on extracorporeal life support for potential reversible etiologies across a number of different topics in the chapter. Those include anaphylaxis, asthma, cardiac surgery, cardiac intervention laboratory, hypothermia, pulmonary embolism, and poisoning such as beta blockers, calcium channel blockers, cocaine, local anesthetics, sodium channel blockers, and sympathomimetics. 2025, we also looked at high consequence respiratory pathogens. This is in response to the recent COVID-19 pandemic. And we looked at those procedures that may be considered aerosol generating and may provide a risk to healthcare professionals managing patients with novel and high consequence respiratory pathogens. So things like chest compressions, bag mask ventilation, defibrillation, suctioning, endotracheal intubation are considered aerosol generating procedures. However, those professionals who use personal protective equipment were ultimately found to have low clinically significant transmission to those team members. So PPE is very important. Next, hyperkalemia. The writing group found very little evidence in support of different pharmacologic interventions to treat patients with cardiac arrest in hyperkalemia. This applies to calcium and sodium bicarbonate. Calcium has almost been dogmatic in the use for management of hyperkalemia. However, in specifically cardiac arrest, there was very little human evidence in either adults or children to support its use. So we worded it so that it is not well established for its use in cardiac arrest. Furthermore, the writing group suggested that the use of beta-adrenergic agonists that may work in life-threatening hyperkalemia has really no role in cardiac arrest for which people are already likely to have been administered epinephrine. Hyperthermia is a new topic for 2025. This relates to environmental hyperthermia, typically when patients in adults and children are greater than 40 degrees Celsius. We recommend rapid cooling, ideally at a rate of at least 0.15 Celsius per minute, and ice water immersion is probably the best and fastest way to cool somebody. Left ventricular assist device is also a new topic for us in 2025. We caution the use of pulses to determine whether a patient is in cardiac arrest when they have a durable left ventricular device. We encourage healthcare professionals to assess perfusion using things like skin color, skin temperature, capillary refill, mean arterial pressure, and partial pressure of end-tidal carbon dioxide. Treatment includes prioritization of CPR, meaning start CPR immediately. Do not worry that you potentially could dislodge a device. So next, I'm going to talk about pregnancy. Patients who are pregnant have a unique complex physiology that leads to modifications of management for their cardiac arrest. Some resuscitation priorities include early airway management as well as left lateral uterine displacement. The 2025 guidelines also updated the algorithm for the management of patients who are pregnant undergoing cardiac arrest. Also included in the new guidelines is recommendations on a very unique aspect of pregnancy, which includes amniotic fluid emboli and how to manage that. And then finally, opioids. Of the toxicology topics, this we found to be important to further highlight. The use of opioid antagonists in patients with respiratory arrest is very important. Also that trained rescuers, lay rescuers, members of the general public can all administer naloxone to people who have arrest for arrest. Now, cardiac arrest in the setting of an opioid overdose is a bit more controversial. However, we do suggest that you can give it a try as long as you're not interrupting high quality CPR. All right, that is it for our chapter. So the next chapter is on education, which looks at how we translate science into practice through training. So thank you very much for your attention.
Thank you, James. This is Ash Panchal, and I'm going to go into a little more discussion about education. The Education Top 10 really features the core concepts needed to optimize the dissemination of resuscitation knowledge and skills. First, we recognize that effective education is an essential component of the formula of survival, and it's needed for all rescuers. When all said and done, good skills starts with good training. And one of the ways you can get that good training is through using CPR feedback devices. These can lead to improved skill performance and should be used during training. Now, most importantly, I think we do recognize that there are clear differences in populations when it comes to awareness, knowledge, and access to CPR education. Our public awareness campaigns and our training efforts should focus efforts in areas where these discrepancies are the greatest, so we can have the greatest impact on our patients. Now, when we think about training, we should also think about training everyone, and that's including children. And children who are 12 years and older can be taught effective CPR and defibrillation. Now, interestingly, for children who are younger, they should also be trained since they will improve their confidence and their willingness to act when they are older. But one thing we do need to consider for all these populations is how we are training people. We want to increase the realism of our training using virtual or augmented reality, but we have to be careful. Virtual reality training has been associated with poor CPR skills post-training. But it is true that if we go down the road of gamification, this has shown to improve learner engagement and knowledge retention. Let's be honest, if you're having fun, chances are you're going to remember the material better, and that's an important piece here. Now, for our instructors, however, it is really hard to debrief some of these resuscitations, so using scripts to guide debriefing can help discussions and enhance our consistency overall. The writing group additionally wanted to highlight the use of rapid cycle deliberate practice during CPR training, because this can lead to better skills post-training. Along with that, we are always looking for new ways to make training inexpensive, more affordable. And so using alternative objects, even like pillows instead of mannequins, will be able to get you there. But there's need for more data to understand the effectiveness of these approaches when it comes to CPR training. The writing group also wanted to call out the need for continued improvement in resuscitation education research itself. And these improvements should be tied to studies with clinical outcomes and even cost effectiveness. This way, we can get more robust resuscitation education and then disseminate this information across the world. Now, those are our top 10, but I do want to focus some of these highlights on specific areas, and I'm going to bring these concepts together. So the first area is the concept of instructional design. With structural design, first of all, using CPR feedback devices, as we mentioned. Also, using scripts for debriefing can be really important. Gamification can enhance our engagement. And last but not least, we should definitely think about VR and AR to enhance the realism of what we're doing with the previous precautions that I mentioned. When we think about lay rescue and general public training, the first key focus is really thinking about the areas that we have large discrepancies in knowledge and access to CPR and targeting these areas to enhance training. Next, really, again, consider children. 12 and older can be effectively trained, and those who are less than 12 can be trained so that they enhance their confidence and willingness and really have that generational effect that we know will be impactful. Last but not least, to mirror back to what James was suggesting earlier, we need to continue conducting research to better help rescuers, recognize and intervene on opioid overdose. Last couple of thoughts in education, I want to focus on the concepts of instructional design again. We mentioned earlier rapid cycle deliberate practice leading to better post skills, but also we need to consider building teamwork training in both our basic and adult life support courses, because this represents a great opportunity to enhance patient safety in our healthcare settings. With that being said, it becomes really reasonable for healthcare providers to take ACLS courses, since this reflects the most updated current guidelines, team-based care, and simulation-based training. And last but not least, we should really think about monitoring the exposures of our clinicians to resuscitation events. And this can be particularly important in EMS systems where sometimes you may not see very many. And with that in mind, we want to ensure competency in the management of cardiac arrest cases overall. Thank you so much for hearing on the key highlights of education. Let's shift gears and dive right into the systems of care. So let's start with the top 10 highlights of systems of care. The top 10 really focuses on our attention on the broad, critical steps to care for individuals suffering from cardiac arrest. We need to consider not only the links in the chain, but also consider prevention and preparedness. That way we can avoid arrest altogether and optimize care when it actually occurs. When we think about this, so much of it is enhancing our systems of care. And this consists of a myriad of pieces that all influence the environment of care we have. From everything from personnel, equipment, resources to quality improvement, all of these tie together. But one of the critical pieces that ties into this is the larger part our community initiatives play in improving lay rescuer CPR. The initiatives we should set up should be multimodal, incorporating training, resources, mobile technologies, all to improve public awareness. Now, importantly, these same goals can be applied both in and in the out-of-hospital setting, because one of the key things that we've realized is there are common components that are crucial for good patient outcome in both of these settings. One of these key components is quality improvement. And using quality improvement to improve resuscitation through debriefing and feedback of rescuers is critically important. This still questions remain about the best way of doing this. What we do realize is this is truly necessary. From the larger system perspective, on-scene resuscitation is preferable to patient transport with ongoing CPR. Let's be honest, this optimizes our resuscitation, keeps our clinicians safer, but on the flip side, it does require training to terminate resuscitation efforts and provide appropriate death notification. It is also important to consider new aspects in the overall system of care. One of these is extracorporeal membrane oxygenation, ECMO CPR. It's a promising but resource-intensive approach. This requires a really organized system to facilitate patient selection and then to have a clear pathway to get that care. Another one of these pieces is cardiac arrest centers. These require clear definitions of the critical components of a cardiac arrest center, as well as additional research to establish the clear transport decisions about when someone gets transported to a cardiac arrest center, may it be from the scene or from secondary transport. Finally, systems of care need to integrate both in and out of patient services to enhance recovery for our cardiac arrest survivors. We now have survivors. Our goal needs to be to support them so they can attain their full neurological recovery. These are the significant top 10 concepts that are in the systems of care section. I do want to highlight a couple of key major changes. The first being that the 4 chains of survival have now been consolidated in a universal chain of survival, which includes adult, peds, and in and out of hospital care. This leverages the identification of some common components to all of these so that they're enhanced together. Another highlight is the importance of public access to naloxone. The writing group provides clear statements that public policies should allow and protect lay rescuers to have and use naloxone to save a life. Now, this includes naloxone distribution programs to increase the availability and, in the end, decrease mortality from opioid overdose. The writing group also, as we noted earlier, is focused on enhancing community initiatives to improve lay rescuer response to cardiac arrest. Now, again, this is multimodal. This includes a bundle of community initiatives like mass media, instructor-led programs, even to the point of thinking about community-based CPR certifications for the general public. All of these are multifaceted approaches to enhance public awareness and training. One area where we don't talk nearly enough about is the possibility of organ donations. With this in mind, institutions should start developing systems of care to facilitate and evaluate organ donation after cardiac arrest. Now, of course, these have to be consistent with local legal and regulatory requirements. Now, the writing group really recognizes that these policies may vary internationally or community-based and are closely linked to the values and cultures of the area. And so these have to be considered when you think about implementing any of these things. Finally, the writing group highlighted the importance of cardiac arrest recovery through integrative systems to support our survivors. We need to continually assess patients' needs all the way from discharge through the point of ongoing recovery and through their recovery journey so we can enhance their long-term outcome. Thanks again. That concludes the education and systems of care sections. Now we'll take some questions from the audience and offer our final reflections. Dr. Maya Dewan will join me for our Q&A and our closing remarks.
Thank you so much to all of our presenters for walking us through the key science updates and what they mean for the future of resuscitation care. It's incredible to see the depth of the evidence and the collaboration that go into these guidelines.
So now I think we're just going to take a look at some of these questions on the side and see how we can help address some of the different questions. I see them on the side here for us. And it looks like there's a couple of questions here. And the first one I see is around pediatrics. Can we use thumb over thumb for chest compressions? I'm going to pass that over to you, Maya. How do you feel about that?
That's actually a great question. And that came up here at ILCOR today when we were presenting side by side the American Heart Association and the European Resuscitation Council. We realized that in the American Heart Association materials, we show thumbs next to each other, as opposed to the European Resuscitation Council, where they show thumbs one on top of each other. Currently, we teach side by side, but there is no evidence that suggests thumbs over top of each other with hands encircling versus thumbs side by side is better.
So the next two I think are well in my space. So I'm going to start with the first one, which I think is an observation. It is understood that if you are a lonely rescuer and witness the collapse of an adult, you first will activate EMS and then start CPR. Completely and utterly agree. If so, trying to activate the emergency response system first is critically important, because then you'll start getting the help that's needed to save the life, and definitely start CPR. The next question is mechanical not recommended due to delay in application, lack of training, or something else. In the back of the ambulance or in a house doing other procedures to achieve ROS, they are a godsend. During compressions, ties up one of two of our ambulance squad, plus the compression rate and depth are inconsistent. What are we missing as far as that is why we don't recommend this? This is a great question. So one of the challenges, and me as an EMS medical director, I face this all the time, is that when we think about mechanical devices, when they first came out, we thought exactly this, that these would be the godsend and they would be the ones that would make a big difference. When they did the randomized control trials for these initially, they had the best type of situation set up. Everyone was trained, everything was great, and they did the best they could. And even in those situations, a couple of the trials actually showed poor neurological outcome. Now, this is in the ideal situation where people's training and application, all that was maximized and optimized so that people were always engaged and able to do these things. So there is definitely something to the gold standard of manual compressions, which goes beyond just our lack of training or application, that affects what's going on. What that is, I'll be honest with you, I am not sure. But there's something that we need to pay attention to, particularly when we see from a large randomized control trial like Paramedic that we're seeing worse neurological outcomes. Now, with that being said, when we think about what we're doing for resuscitation, especially in the unstable and uncertain environment of the pre-hospital care and the back of an ambulance, we have to weigh those abilities to actually provide good care versus like optimal ultimate care, right? We have to balance that all out. And sometimes the best decision is to do mechanical CPR because that keeps people safe as we're doing our care. I hope that helps with that discussion.
Let's see, do we have any more questions? I think that might be it, Ash.
Okay. I'm not seeing any new questions pop up. Excellent. Well, thank you all for those thoughtful questions, and to everyone who joined our discussion today. We're so grateful for your engagement and for being part of this incredible global community advancing resuscitation science and education. Today's conversation has been an inspiring start to Guidelines Launch Day. It's connecting the science to the systems and the people who bring it all to life.
That's right, Ash. As we've seen, these 2025 guidelines represent the most comprehensive review of resuscitation science yet, grounded in evidence, collaboration, and our shared goal of improving outcomes for every patient everywhere. We also hope you'll carry forward what you've heard today, not just in your own practice, but into your teaching, into your advocacy, and especially into your local communities.
And we're just getting started. Up next at 12:45 p.m. Central Time, we'll continue the conversation in the training implementation webinar, where we'll explore how this science translates into teaching and course delivery across BLS, ACLS, PALS, and HeartSaver. You'll hear from leaders on the American Heart Association education team, along with some association volunteers and association product development staff members. They will share the practical insights and what the updates mean for you.
Thanks again for joining us for the Science Overview webinar and for your dedication to saving lives through science education and action.
On behalf of the American Heart Association, I'm Os Panchal.
And I'm Maya Dewan. Enjoy the rest of your day.